TopMedTalk.
Welcome to TopMedTalk. We are here in Chicago at the Society of Cardiovascular Anesthesiology's 41st annual meeting. I'm Desiree Chappell, host and managing editor of TopMedTalk, and I'm joined by Monty, Mythen, editor-in-chief. Hello, Monty.
Hey, Desiree. Great meeting.
Yeah, it's been fantastic. Isn't it near and dear to your heart? Cardiac anesthesia is where you started, right? Is that where you started?
It is, yeah. That was most of my life early on was as a cardiothoracic anesthesiologist.
Yeah.
And just to say, when he introduced himself to me, I said, "Oh, because that's a name that you know."
Oh, you're Monty, Mythen.
I said you are him.
Yeah.
Oh, except two extra voices. Oh.
I'm actually really a Michael, so you got two Michaels on the couch here.
That is true. That's true. Okay, before we get, you've heard two voices here. Saul Aronson, our friend of TopMedTalk, and past president of SCA. Right?
Indeed.
We're not going to ask you when that was,
Please
Saul.
don't.
I won't, I promise. And the other voice you heard here was Dr. Michael Eaton. Michael, thank you so much for joining us.
My pleasure.
All right, so you are, let's see, get this in here, the professor and chair of anesthesiology and perioperative medicine at the University of Rochester in New York.
Right.
Yeah.
The other Rochester.
The other Rochester. But you also are the chair for the meeting this weekend, yeah.
Correct. I'm the chair of the scientific program committee that plans and executes the meeting.
Yeah, so you feeling like your baby is here and this is all happening and...
Yes, which is both enormously satisfying and anxiety-provoking at the same time.
Sure. You're handling yourself very well. You don't seem stressed.
It's all on the inside. Well, this is anesthesiologist, right? So you have to appear calm no matter what's going on inside.
That is for sure. So what are your thoughts for the meeting when you guys were planning and getting the meeting put together, what you really wanted to accomplish for this year?
Well, I think we wanted to have a great meeting and not upset what's worked really well in the past, but to make sure we were covering topics that were emerging and not do the same thing all over again. One of the great things about this meeting, and I first came here as a resident, which is a long time ago, 20, 30, less than 30 years ago, but close, is that every time I've come to this meeting, and I hear this from many trainees and many cardiac anesthesiologists, it's just a great meeting. It's a great experience to go to. And in a time when in-person meetings are becoming less popular, people, particularly in anesthesia, but I think in medicine in general, have less time to travel to meetings, that this meeting has maintained relevance, it's maintained importance to people, and people are willing to make the trip. So, we've done a great job having the annual meeting for 30 years. Don't screw it up is a leading important thing. One of the other things that we tried to address this year and will going forward is that at many medical meetings nationally, there's a preponderance of men speaking from the podium, and not too many women and not too many underrepresented minorities. So we made a conscious effort to include women, and it's not too hard to find women who are leaders, thought leaders, well-published, well-known in cardiac anesthesia. It's just addressing the intrinsic bias that we have when you think of 4 people for a panel or even 28 people for the committee, that you think of a bunch of men.
Yeah, it's true. Well, that's your pool. I mean, that has been the tribe for a long time. So I think being cognizant of that is very important. We were able to sit down with Sasha Shilcutt just a moment ago, and she was telling us a little bit about just how you guys are expanding the meeting and doing workshops and having speakers, but having panels and fireside chats and doing all these other things. So really changing up the program, I think, it's been really good.
Yeah, I think the fireside chat is a relatively new thing, and I think that came about when you were president, Saul, was it?
Long ago, right? Yeah.
Not that long ago.
We're not asking.
Right,
Monty?
right.
So Mike, what's in cardiac, per se? I do more thoracic these days. What's really hot? So in sort of non-cardiac surgery, prehabilitation, shared decision-making, the sort of holistic care, what's really hot at the moment? So
I'd say off the top of my head, there's a couple of things that are very important. One is structural heart, which, if you're not in the cardiac world, you go, what's structural heart? All right, the heart has a structure. So, that is the movement of interventions from the operating room, essentially, to the cath lab or a hybrid suite, something like that. So that what we used to do we used to do in maybe 3 hours in the operating room now takes perhaps a little bit longer, and it involves lots of catheters and through snaking through arteries and veins with a team with variable compositions, sometimes involving anesthesiologists, sometimes not, and sometimes involving surgeons and sometimes not. So that is a rapidly evolving general area, and obviously foundational is what are we going to be and do as cardiac anesthesiologists going forward. The other thing that is up and coming, and is you talked about a little bit on the edge of it anyway, is ERAS, or early recovery. ERAS actually is a registered trademark, I think. So ERAS.
You're allowed to say it. It's only the way they wrote it they can trademark. You can't trademark the letters.
In the podcast, we won't have to worry about it.
You're all good.
You said it in the non-trademarked way.
There you go. So ERAS would just throw cardiac in there, and early recovery, enhanced recovery. And really, that is something to hang our hat on, that term ERAX, but it's really how do we, as perioperative physicians, expand our role and fill in some holes, improve the care, the preoperative preparation of the patient, and the postoperative follow-through, so the patients have a whole experience that is more likely to produce good outcomes, including patient satisfaction, which is absolutely an outcome in 2019.
Yeah, absolutely. So what are some of the lectures that you're really excited about hearing in the next couple days? I mean, besides all of them, I know. I'm so sorry, but there's sometimes that you're really excited about one, particular topic that you think is just going to take down the house.
I'm actually going to take it back to yesterday, and I'm sure there are lots of great topics coming up.
We know that.
I'm generally poor at pulling them out of my head, but I can tell you that yesterday, the refresher course lectures, the very first session, Annette Schwann gave a talk about the Cpi Initiative, which is the Clinical Practice Improvement Initiative that the SCA has been on about just for the last few years. And essentially, looking at the overall problem, it's a problem in medicine that we establish evidence base for improvements in care, and then we don't do them. So it takes, even when we do make changes that we feel are improving care, it takes years. Yeah. Many years. And so we're very slow moving. Now, to some extent, that's good because we're thoughtful and careful. But to some extent, we miss the boat, and we don't actually improve care. So the society, other societies, ACCHAs, particularly active in this area, publish guidelines. They do an enormous review of literature, hundreds of papers. They distill it into, all right, what does this evidence actually say? And they publish a 40-page paper. Mm-hmm. That is difficult to access. And so what the Cpi Initiative is saying, look, all right, let's crunch this down a little bit. How does this really apply to me today, and to how I should do? Give me a digestible bit. Give me a way of how I can address this. And I thought, unfortunately, there were some technical issues around the slideshow, but I think Nanette did an extraordinary presentation about what we're about, and really a passionate call to action during that talk about what we need to be about as a society, as a group of cardiac anesthesiologists, individually as anesthesiologists.
So I think the saying, if I'm right, Michael, is that the greatest innovation would be if we would just do what we know. Is that right?
I think that's probably right. I think first you have to agree on what you know, and knowing is a complex thing. And there are times when we've made missteps. CMS has been probably more aggressive about this than physicians would be otherwise, and made a fuss about starting patients at risk for bad cardiovascular outcomes perioperatively, starting them on beta blockers based on a fair amount of evidence. And then another paper came out and showed that actually increased mortality. Yeah. So you've got to be careful about what you know and what you think you know.
So in the context of CPI, and I recall even back in the days when I used to sit in the room, that was a twinkle in our eye many, many years ago. The science of implementation, the science of adaptation, the science of translation is a science unto itself. How are we converting? How are we transferring the information we know to the adaptability of the user?
It's a great question, Saul, and I think we are really, if you're talking about the SCA, we're really starting down that road. And they have now for the blood conservation recommendations, and they're working on, I think, recommendations for acute kidney injury prevention. They're starting down on a relatively small number of topics so they can really hammer out what do we know, package it for delivery. I just got an email from Nanette, actually just read this morning, and talked to Chris Troyanos, the outgoing president of the SCA, about how you get to the implementation. What Nanette had said is, look, I think this is great what we're doing now, but I think we need to be able to push this to the local level, because all change, all politics is local, and that's true in medicine and the hospital as well. And how do we get leaders locally to take this that we're putting together, a sort of consolidation of evidence and practice, and make it actually happen? And that resonated for me right away. I don't think we're doing that yet, but I think we're talking about how you get to that next level.
Very, very difficult. I have a saying: between data and change is reality, and reality is emotion, reality is trust, reality is culture, and reality is easy to do. And if you can't get over emotion, trust, culture, and easy to do, you'll never see change.
Yeah. And I think all of those words were in Nanette's presentation. And the realities, the trust, those are all definitely issues. The easy, I think, is a lot of what CPI is about, right? Is to get away from that 40-page consolidation of the evidence to easy, and I remember her saying easy now because I'm thinking, that's just the button.
The easy button.
The easy button, right.
Because we relatively recently in the UK had published a very large quality improvement trial. It's about 17,000 patients. And by having a very complex quality improvement program with a light touch of support, it made absolutely no difference at all. Meanwhile, in parallel, there's another publication where they put a team in there to provide lots of support, and they only asked them to do 6 things. They made it. You could remember 6 things probably. Even if you remember 4, that's a move forward. And that had a big impact on outcome by just saying, it's interesting to know Professor Henrik Kellett's original publication only about enhanced recovery only had 5 elements in it, and it's become 25. He had 5.
Yeah, we sometimes have to swing the pendulum one way and then maybe swing back and bring it back down.
Keep it simple.
Just keep it simple, sweet.
That's it, yes. The KISS method.
The KISS, yeah. I mean, you kind of laugh, right, when somebody says that, you kind of laugh at it. But, I mean, in reality, that is reality.
Well, you look at, and this is part of the reason that we don't make change in medicine, that we are all running as fast as we can to stay in the same place. Yeah. And it's, I heard Bruce Beese make that analogy at a talk he gave at this meeting a few years ago, and I believe it's from Alice Through the Looking Glass, where Alice is running with the Red Queen, no longer the Queen of Hearts, but the Red Queen, and they're running very fast, but they don't seem to be getting anywhere. And Alice says, "This is very odd, but if I was at home and I ran this fast for this long, I would have gone a very long way indeed." And the Queen says, "Well, that's very odd, because here you have to run this fast, this long, just to stay in one place." And that's where we are in medicine. We are working our butts off to just keep our heads above water and do what we do every day. So that 40-page paper, that's just not going to be digestible and practical for us. It's not going to be easy. And so those 4 things or 6, whatever it is, those are the things that I think can be helpful and make change.
Yeah, well, it's great that the SCA has recognized that and providing support there, because we can talk all day long to the masses and try and get the word out there, but trying to translate it into practice is important. And somebody needs to take the initiative on that, I think.
Right, and that is, that's our mission. Right?
Yeah.
Our mission isn't just to put on a great meeting and to tell people things, but our mission is to make care better. Our mission is to improve outcomes of patients having cardiovascular surgery and procedures.
Yeah.
So, and that's, that is a tough nut, but that is what we should be about.
Yeah, absolutely.
On the other end of the program spectrum, I love, and I've noticed, that we have such a great engagement with fellows and young faculty and the generation that's going to, pick up the baton and keep running. How does this society stay connected to what that generation needs, and how do you deliver on that?
That's good.
Yeah, that is a tough one, Saul, and that is something we've struggled with. We have, looking at membership in the past 5 to 10 years, had a significant drop-off in membership. And one of the things that we hadn't done well is have fellows in particular who had been members as fellows continue. And many of them did not renew their membership. And last year at this meeting, we had a town hall where we engaged residents and fellows and young faculty and say, hey, what are we doing wrong? What do you need? Right. And I think that's step one, is understanding. What we're also doing is restructuring the board to include young, more junior people. I think from the outside, the SCA is probably viewed as a clique of academic, old people. Almost use another word there, but older established people who are, have all written textbooks, etc.
Yeah.
And I can never be in that group, and nor can I influence it. Well, we need to change that dynamic.
Yeah.
So we're engaging people even at the leadership level, and I think we have to move into the area where how people interact and learn. So it's not necessarily going to be like this, although that we're going to have roughly 1,000 people at this meeting. And as you say, many of them are young people. That's great. But I think getting to the point where we're on your hip and we are a go-to resource.
Some of them are going to be listening to this podcast. You want to do a shout-out to them?
So the shout-out is we are hoping to try and move it in your direction, but some of us are old fossils, and we need your help, and we are very, very interested in what residents, fellows, and junior attendings, and I say attendings, not junior faculty necessarily, but certainly, but also people in private practice. We that is another pool that we have struggled a little bit to engage because they're not necessarily as cohesive as the academic group. But boy, that's at least half the membership of the SCA. We need to engage private practice people as well.
Need those people represented. Yeah,
absolutely.
Monty.
And the journey towards fuller engagement of multidisciplinary practitioners in the space. Where's the society on that one?
I think that's a tough one. I think we have viewed ourselves in the name as a society of anesthesiologists. We certainly involve surgeons, cardiologists, and others. Just ran into one of our own perfusionists who's here participating in a workshop as educators and participate. We reach out to, particularly to surgical societies, and participate in cardiology societies, in educational programs and in clinical practice improvement initiatives. I think that is where we are there. We have not necessarily brought those people into the fold of the SCA, but it's definitely something that we have talked about.
I'm a CRNA, and I've been doing hearts for 10 years, so I've never been to the SCA, and this is really fantastic. Some of the information, so I think.
Right. So we can talk about this. You're a CRNA. I'm sure you are well aware of the dialogue at the national level, which I don't know how you feel, but I feel it's just enormously destructive and foolish. Yeah. And we're squabbling over territory, and there's lots of territory to be shared there. And I don't think either organization is really looking at what is best in the long term for the perioperative outcomes of surgical patients.
It just made I know the CRNA. I understand a little bit. I think about the CRNA and physician anesthesia provider thing in the USA. Let's call it a thing as opposed to attention or something else. But what about the critical care nurses, for example? Because a lot of the patient almost always goes to an environment where we have, to a certain extent, a devolved care model, where we are asking our critical care nurse colleagues to do this sort of continuous bedside care of that patient. And we're not sharing necessarily that learning at the moment.
No, that's true, and that's almost all I can say about that. It is something that has come up, particularly when we're talking about we have a SOCA session, Society of Critical Care Anesthesiologist session, and that has come up as, do we bring critical care nurse in? Do we involve them in that particular area around critical care? A lot of what we talk about, of course, is operating room, but certainly critical care and prehabilitation. So nurses and other care providers that provide care in the pre-operative process as well. So I think we're probably not where we should be with that. But it's a good point, but we do think about it.
It's a process. It's the continuum. Sorry.
No, I was just saying this opens up such a abyss of opportunity to have discussion and certainly fodder for future programs to focus on. I just love the general topic of where we're going as a industry in healthcare in this country in general, and obviously through the lens of cardiovascular care and through the more narrow lens of cardiovascular anesthesiology care, it just flows. But I keep reminding my colleagues and everybody who's willing to listen to me that it's really about total cost of care and two-sided risk. And if you look at these topics through that lens, it flows relatively easily. You must do things with a value point of view. And all those other topics solve themselves.
Yeah, absolutely.
Wonderful topics for future meetings, and I look forward to the SCA engaging in that because I think we do have a responsibility and role as leaders and the specialty to drive that discussion.
Yeah.
Oh, I agree, and I think that is space we need to be in. No question.
Yeah. Well, something to look forward to. Well, congratulations on a fantastic meeting so far, and I wish you the best of luck over the next couple days, and look forward to it. Thank you so much for sitting down with us.
Oh, my pleasure.
Fantastic.
I'm glad I could do it.
Yeah.
Thank you, Mike.
Thanks, Michael.
Thank you so much.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.